Welcome to today's 3M Health Information Systems webinar. My name is Jared and I will be your host for today. We'd first just like to start off by saying that we greatly appreciate your attendance today during this sensitive time in our country and really across the world. In light of the circumstances, the majority of our team members are working from home today. So if we have any technical issues during this webinar, we apologize in advance and we'll work to get them sorted out as quickly as possible. In today's webinar, we will review COVID-19 updates for the inpatient population. We encourage you to ask questions throughout the presentation. You can do this by using the questions feature in the web meeting controls, which is located in the lower right portion of your screen. We are also recording today's presentation, and a webinar archive will be available, so look out for an email from the next week that includes a link to the archive. A PDF that contains all of the presentation slides is available for you to download, and that's located in the handout section of your web meeting controls. We'll also provide a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar. Without further ado, today's presenters are Cheryl Manchinton and Audrey Howard. Cheryl has been a nurse for more than 31 years and has worked in clinical documentation integrity for over 11 years. She is currently a senior inpatient consultant for 3M Health Information Systems. Audrey has more than 25 years of experience in health information management. During her professional career, she has worked as a coder, DRG technician, coding supervisor, and assistant director of an acute care health information management department. Currently, she is a senior outsourced services consultant with 3M Health Information Systems. Audrey, I know we're all excited to get started, so I will turn the time over to you. Audrey, you might be on mute.
Yes, I was. My mute button does work. So sorry about that, everybody, and that's the first glitch of the day. Hopefully that will be it. During today's presentation, we will cover the accurate code assignment as well as the coding updates related to COVID-19. In addition, we will discuss the COVID-19 clinical updates. Before we get into the presentation, let's start off with a polling question. Jared, I'm sure you have now opened up the polling question. Thank you very much. As you answer this question, thank you. As you answer this question, I hope that everyone is staying safe and healthy. We are certainly going through some unprecedented times in all facets of our lives. So this question is related to any of your workforce reduction. Yes, do we have the results?
Yes, we'll just give it just a second longer. It looks like there's still several coming in here. Just give it maybe another 10 seconds. Okay, closing out the poll. Okay, so 51% said less than 10%, 20% said between 11 and 25%, 16% said between 26 and 50%, and 7% said between 51 and 75%, and lastly, 5% said more than 75%.
Thank you so much. Wow. I am happy to hear that over half is less than 10%, but it's still disconcerting to hear that 12% is over 50%. That is amazing. Cheryl Manchinton is also with us. Cheryl, did you have any comments on the poll results?
Thank you, Ms. Audrey. I echo Audrey's comments about hopefully everybody is safe and well. And of course, we would not wish any of these workforce reductions because even that 10%, right? If you're a member of that 10%, that's not a good day for you as an employee. So please know that, you know, we care. We at 3M in our division, our consulting division, are very strong advocates, by the way. You know, I'm doing as much as possible, I know Audrey as well, in saying, you know, now more than ever, we really need as many people working as possible to get really accurate representation of our times. But again, you know, and I'm happy it was only that 5%, but again, those poor clients that, one of my clients actually had 100%. So
Oh, my.
Very frustrating. Yeah.
My goodness. Well, thank you for responding to that. Okay, let's go ahead and get started with a discussion on the codes and the coding updates related to COVID-19. Because of the declared public health emergency, the World Health Organization created an emergency ICD-10 code to identify this new coronavirus. With the pandemic, the United States decided to fast-track the implementation of the COVID-19 code. Code U07.1 became effective on April 1st, 2020. When COVID-19 meets the definition of principal diagnosis, code U07.1 should be sequenced first, followed by the appropriate codes for the associated manifestations. From a coding standpoint, this new code was approved and implemented at the speed of light. This is the only new code that has been implemented related to COVID-19 in the United States so far. It is anticipated that additional new codes will be created and implemented effective October 1st, 2020. Please stand by for those announcements. However, coding guidance has advised us to use other already existing codes to be able to track other scenarios related to COVID-19. Advice related to COVID-19 is also being published at the speed of light as compared to the rate advice was previously published. Therefore, it is extremely important to stay updated on the current advice and to continually go back to the sites of the published official advice to ascertain if any information was again updated. Code U07.1 was added to 3 different MDCs. The most common MSDRGs will be assigned to MDC4, the respiratory MDC. This is MSDRGs 177, 178, and 179. These are the same MSDRGs where the complex pneumonias are located. If COVID-19 is sequenced as a secondary diagnosis, it is classified as an MCC. From an APR-DRG standpoint, COVID-19 is also added to 3 MDCs, with the most commonly assigned APR-DRG being 137. Please note that COVID-19 will default to severity of illness level 3 and risk of mortality level 2. If the provider documents suspected, possible, or probable COVID-19, do not assign code U07.1. Instead, assign a code or codes explaining the reason for encounter, such as fever or exposure to someone confirmed to have COVID-19. This is an exception to the uncertain diagnosis coding guideline. In addition, according to the new official coding guidelines for COVID-19, presumptive positive COVID-19 test results should be coded as confirmed. A presumptive positive test result means an individual has tested positive for the virus at a local or state level, but it is not yet confirmed by the Centers for Disease Control and Prevention. CDC confirmation of local and state tests for COVID-19 is no longer required. Code assignment is based on provider documentation per official guidance. According to the official coding guidelines, confirmation does not require documentation of the type of test performed. The provider's documentation that the individual has COVID-19 is sufficient. However, the official coding guidelines also state code-only confirmed diagnosis of COVID-19. Therefore, if the provider documents the patient has COVID-19, then code U07.1 will be assigned regardless if the patient was tested or not. However, if the provider is documenting the patient has presumed COVID-19, then a query may be necessary to clarify what the provider intended to mean by documenting presumed. If presumed means the provider cannot confirm the COVID-19 diagnosis, then do not assign code U07.1. If presumed means the provider is confirming COVID-19 despite not testing, then assign code U07.1 for the confirmed case of COVID-19. We have been having many internal discussions around the definition of presumed and presumptive, and if it should be classified in the same way as possible, probable, or other uncertain diagnosis terms. 3M is reaching out to AHA Coding Clinic for direction. If COVID-19 is ruled out, then assign a code for the circumstances of admission, such as another condition, such as pneumonia, or the presenting signs and symptoms, which could be fever, if no other related definitive diagnosis is documented. If no symptoms are present, then a code for exposure should be assigned, which will be discussed later. If COVID-19 meets the definition of principal diagnosis, code U07.1 should be sequenced first, followed by the associated manifestations. Sequencing of the principal diagnosis is dependent on the circumstances of admission and must be decided on a case-by-case basis. If the COVID-19 does not meet the definition of principal diagnosis, then it will not be sequenced as the principal diagnosis, even if it was present on admission. For example, if a patient is admitted with pneumonia due to COVID-19, which progresses to viral sepsis, not present on admission, COVID-19 will be sequenced as the principal diagnosis, followed by the codes for viral sepsis with the POA no and viral pneumonia. However, if a patient is admitted with sepsis due to COVID-19 pneumonia and the sepsis meets the definition of principal diagnosis, then the code for viral sepsis should be assigned as principal diagnosis, followed by the codes for COVID-19 and viral pneumonia as secondary diagnoses. This is following the guidelines stating to sequence the systemic infection first, followed by the localized infection. For HIV and COVID-19, the sequencing will depend on the circumstances of admission. The HIV will cause the patient to be at higher risk of becoming infected with COVID-19 because they are immunocompromised. But HIV does not cause COVID-19. The newborn code will be sequenced first with the COVID-19 code as a secondary diagnosis. If a baby is transferred or readmitted, so it's not their birth admission, then the sequencing depends on the circumstances of admission. We will discuss the coding for pregnancy with COVID-19 in a few slides, but it is important to note that the COVID-19 will not be sequenced as principal diagnosis if the patient is pregnant or within the postpartum period, which is 6 weeks after delivery, unless the provider explicitly documents the COVID-19 is not affecting or affected by the pregnancy. This slide is showing the common respiratory manifestations related to COVID-19 and the appropriate code assignment. In all of these situations, code U07.1 will be sequenced as the principal diagnosis with the resulting MSDRGs including 177, 178, or 179. The APR-DRG will be APR-DRG 137. Please note the provider does not have to explicitly link the positive COVID-19 test result to the respiratory illness in order to code the U07.1 as the principal diagnosis. Acute respiratory failure as a common respiratory manifestation was not included in the official coding guidelines. However, it is possible the patient may experience acute respiratory failure related to COVID-19. The appropriate code from category J96 for the respiratory failure will be sequenced as a secondary diagnosis with the COVID-19 sequenced as principal. Now, there are times the provider documentation may include both acute respiratory distress syndrome, ARDS, and respiratory failure in the same record. However, only the ARDS should be coded when both are documented based on coding directives under respiratory failure category. There is an excludes one note under category J96, which excludes acute respiratory distress syndrome, J80. The excludes one note means the condition is not coded here. In other words, it is coded to the code listed in the coding directive. If a patient is admitted with acute respiratory failure, which later during the same hospital encounter progresses to ARDS, then only the code for ARDS is assigned with POA Y for yes. Per recent coding clinic advice, when a condition evolves during the stay, such as mild to severe malnutrition, the more severe condition is reported with the POA of yes. This is from Coding Clinic 2020, first quarter, page 5. As ARDS is a type of respiratory failure, the ARDS is reported as POA, present on admission, although they were only in failure on admission. The patient had signs and symptoms related to the condition which progressed in severity during the encounter. Now let's go on into some of the coding information for exposures. To report a possible exposure to COVID-19 ruled out, use Z03.818. According to the instructional note under category Z03, a code from this category is assigned when a person is suspected of having a condition without signs or symptoms, and after examination and observation, the condition is ruled out. If a patient presents with symptoms and the COVID-19 was ruled out, it is appropriate to assign codes for the presenting signs or symptoms, such as cough, fever, or sore throat, since the COVID-19 was ruled out and there was no other definitive diagnosis. Based on coding guidelines, this observation code can only be sequenced as a principal or first listed diagnosis. And really, the code will be used in rare situations. It's not going to be commonly assigned. To report actual exposure to another individual confirmed to have or suspected to have COVID-19 and the test results are negative or unknown, use code Z20.828. If the exposed individuals test positive for COVID-19 virus, use code U07.1 for confirmed provider when the provider documented confirmed cases of COVID-19 instead of this exposure code. So always, if the patient is tested positive, the U07.1 code would be assigned instead. An example of the application of code Z20.828 is a patient presenting with respiratory signs or symptoms, testing negative for COVID-19, and the patient is determined to have another condition such as the flu or pneumonia. Code should be assigned for the condition, such as the flu or the pneumonia, and code Z20.828 should be assigned as an additional diagnosis. The use of code Z20.828 does not require explicit documentation from the provider of known or suspected exposure to COVID-19. The expanded use of code Z20.828 allows us to track potential COVID-19 cases. Now this, I do want to point out, the advice for code Z20.828 has been growing since the initial advice was printed. So this is one that they were giving us limited times that we could use this code, and then they were allowing for more and more because of the pandemic that we're going in and the desire and the need to be able to track these types of cases. Asymptomatic patients screened for COVID-19 with no known exposure is classified to code Z11.59. If the patient is screened due to possible or actual exposure to COVID-19, then use either Z03 or the Z20 code that we previously discussed. Code Z11.59 can only be used if negative or unknown test results. If an asymptomatic individual is screened for COVID-19 and tests positive, then we would assign code U07.1 to show the positive COVID-19 results. An example would be a patient needed to be tested prior to being accepted by the SNF. Patient had no signs or symptoms related to COVID-19, and the patient has no known or suspected exposure to the virus. So in that case, the patient was simply being screened to be able to get admitted to the SNF. They were being discharged from an inpatient setting, wanting to go to a SNF. They had to be screened before they could go in there and be testing negative. As in any other circumstance, if the patient has signs or symptoms without a definitive diagnosis established, assign codes to report the signs or symptoms such as cough, shortness of breath, or fever. Do not assign code U07.1 in this circumstance because a definitive diagnosis was not established. As indicated earlier, if a patient with signs or symptoms associated with COVID-19 also has an actual or suspected contact with or exposure to someone who has COVID-19, it is appropriate to assign code Z20-828. As I stated earlier, the inclusion of this code on records will help us track cases. Signs and symptoms that are not routinely associated with a diagnosis may be reported as a secondary diagnosis. Because COVID-19 is primarily a respiratory condition, it would not be appropriate to add these respiratory signs or symptoms as secondary diagnoses in a COVID-19 patient because they are inherent with COVID-19. However, other signs and symptoms such as gastrointestinal problems are not inherent with COVID-19 and therefore may be coded as a secondary diagnosis as long as they meet reporting criteria such as evaluation, monitoring, treatment, increased nursing care, or increased length of stay. Now, although a patient is asymptomatic, if the individual has tested positive, they are considered to have COVID-19 infection and code U07.1 is assigned. The positive test result code can be coded as confirmed code for COVID-19 cases as long as the test results are a part of the medical record. Code U07.1 may be assigned based on results of a positive test as well as when COVID-19 is documented by the provider. Now, this advice is limited to cases related to COVID-19 and not the coding of other laboratory tests. As in all coding situations, code assignment is based on provider documentation. If the provider has documented COVID-19 as a definitive diagnosis prior to test results and the test results come back negative, it would be appropriate to query the provider for confirmation of the final diagnosis. The provider should be given the opportunity to reconsider the diagnosis based on the new information. If the provider still documents and confirms COVID-19, even though the test results are negative, assign the code U07.1. The provider's documentation that the individual has COVID-19 is sufficient. Once again, code assignment is based on the provider's documentation. So what do we do if a patient is readmitted shortly after treatment for COVID-19 for an entirely different reason? Once again, code assignment is based on the provider documentation and it depends on the circumstances of admission. If the documentation is unclear, if the patient is still being monitored for or treated for COVID-19 during the current encounter, then I recommend querying the provider for clarification. If the patient no longer has COVID-19, then assign code Z86.19, which is a personal history of other infectious and parasitic diseases, as a secondary diagnosis. Code U07.1 would be assigned when it meets the definition of a principal diagnosis on a subsequent visit via evaluation or monitoring. Most often, it would be hard to determine without clarification if it is an ongoing infection. For pregnant patients admitted with COVID-19, the pregnancy code has to be sequenced as the principal diagnosis, followed by code U07.1 as a secondary diagnosis. The pregnancy code always takes sequencing priority. Now, if a pregnant patient presents with signs or symptoms associated with COVID-19 and has known exposure to the condition, but tests negative, we're still going to assign a pregnancy code first. It would be O99.89, along with the codes for the signs or symptoms that the patient presented with. It would also be appropriate to code Z20.828 as an additional code in this situation as well. Okay, shifting away from COVID-19 for a little bit, I want to point out that there are some code assignments available for SARS, and this is the severe acute respiratory syndrome. However, SARS is not the same as the COVID-19. So these codes that are listed on the screen are not used if the patient has documented COVID-19. Although they may sound similar, they are not going to be similar. And the coding guidelines that have been published so far have made a point, basically, to assign a different code for COVID-19 and not using the existing SARS code. So these codes are not to be used if the patient has been diagnosed with COVID-19. I also wanted to bring up some procedures that were available related to some COVID-19 cases. We have all heard about ventilators, and ventilators are under increased need and being shipped to states. There are 3 codes that are available depending upon the length of time that the patient is on a mechanical ventilation. So it goes from less than 24 consecutive hours, 24 to 96, and then greater than 96 consecutive hours. And it's very important for us to be able to count the hours correctly that the patient is on the mechanical vent, because it could impact on the DRG assignment. So because of its importance, we want to make sure that we do follow the guidelines that were available. And there was a great coding clinic on this. The reference for this is listed at the end of the slide deck. But it kind of reminds us as when can we start the clock of when the mechanical vent can be started. So that could be at the time of the endotracheal intubation, and then with subsequent initiation of mechanical vent. Is it initiation of mechanical vent through a trach? Or is it when they are admitted, because the patient may have been previously intubated outside of the hospital? So at the time of admission, then we would also start the clock for the mechanical vent. What mechanical ventilation coding does include is the weaning period. So if they're on a mechanical vent, they're trying to be weaned prior to extubation, that weaning period is a part of the consecutive hours, so we keep the clock going. If they are doing BiPAP or CPAP through the endotracheal intubation or through the tracheostomy, that is also included in the mechanical vent coding. And then if they are doing the mechanical vent through the tracheal tube directly into the stoma, then that also is counted as a mechanical vent. What it does not include is ventilation that's provided as a part of the surgery. That means it's inherent to the surgery. That's not included in the clock counting for how many hours they're on the vent. And then if that's the only time that they're on the vent. And then oxygen delivered via tracheal mask. Also BiPAP, CPAP alone, not through the intubation or through the trach. That is not included in a mechanical vent. Also, I wanted to review some of the codes that were available for ECMO. And there's 3 different procedure codes that are available. One for central ECMO, one for peripheral veno-arterial ECMO, and then another one for veno-venous ECMO. So different codes. Now, they all should be going to the same DRG now. As of October 1st, they decided to put them all into the same DRG. But we want to be able to pick up appropriately if a ECMO is used, that we are assigning the right procedure code for it. And then also in the news lately, we've been hearing how COVID-19 patients are having to go on hemodialysis. So this is, we do have, once again, 3 codes that are available for the hemodialysis, depending on the hours in the day that are being used. But more than likely, you're going to see it documented as CRRT, which is your continuous renal replacement therapy, or SCUF, which is your slow continuous ultrafiltration. Both of those are meaning continuous, which would be going to the 3rd code that's on the right-hand side over here for the continuous hemodialysis. Okay, at this point, I would like to turn it over to Cheryl Manchinton, who will open up with our polling question and then go into some clinical information related to COVID-19.
Thank you, Audrey, and thank you, everyone. So if we could open the polling question, please. So I think this is also a hot topic that we've all. Thank you. I think this has been a hot topic, across the country. When are we going to open up elective surgery? So again, just curious to see. I think it really is very dependent on what region we're in or if we're in a hot spot. But curious. Is once they think the peak is passed, how quickly after that have we seen our hospitals reopening? And if you could go ahead and display the results, please.
Okay. So we had 53% said within the next 2 weeks, 10% within the next month, 3% the next 2 months, and 34% said other.
Great. So again, I think the good news is for those 50%, I'm glad that we're starting to see those elective surgeries come back. Of course, I know one of my particular clients, I said, we're starting them, but we're starting limited operating rooms, that they're phasing in those operating rooms and slowly ramping that back up. It's not a light switch. It's more like a dimmer switch that we're turning back on. And of course, we know why this is so important, because our surgical cases, of course, are more highly reimbursed, and we actually do a little bit better in DRG payment in terms of the cost of care. So I know that a lot of us are hoping that this surgery starts up soon, and of course, a lot of our furloughed employees are from those areas where we've got those surgical centers. So thank you for that, and let's see if it does work. Indeed. Okay, good. Let's see. Hang on here. Seeing if my controls work. It does. Okay, COVID-19 clinical stuff. I think it's always really helpful that Audrey and I do this together. We really are 2 halves of a coin. For those that have seen our previous handouts, I am doing a little bit of repetition and then a little bit of expansion from when we first presented. As Audrey said, our information on coding has really constantly changing, but so is our clinical understanding of that. So let's talk about the neurologic manifestations. We do know that a lot of our patients do come in with altered mentation. So what terms are we looking from our providers? It could be something as simple as delirium, okay, or encephalopathy. We're not going to give you a definition. We want you as an organization to use that definition the same way you would for any other patient with an altered mental status. I don't think that we need to discriminate and say encephalopathy looks like this in COVID, but it looks like that in sepsis. But of course, encephalopathy doesn't tend to wax and wane. That's more of a delirious state where they're up and down in their mental status. Don't forget other terms, though, that we can look for or that we're able to capture is documentation of comatose or, again, those Glasgow Coma Scale scores. Okay. What I found really interesting was there was a recent study in the Journal of American Medicine Neurology, JAMA, where they really had sorted or categorized our neurologic manifestations into 3 categories. Our CNS manifestations, okay, are peripheral and there are others. So let's talk about the CNS ones. Symptoms such as the dizziness and headache that so many of them have had, and of course, the mental status that we were talking about. But what has been, I guess, the most concerning or frightening has been the acute cerebral vascular disease, where they've had either hemorrhagic or ischemic strokes. I was actually reading an article with an interventional physician that he was doing a thrombectomy on a patient with COVID. And as he was pulling this giant clot out of this patient's artery in his brain, the body was making more clots right in front of this provider. I mean, can you imagine that they were literally growing and expanding? That is how vicious this clotting disorder has been. But again, they've been both hemorrhagic and ischemic. And with the ischemic strokes, they've been particularly devastating because they're very, very long and dense clots. In addition, of course, to that, we'd have either ataxia or seizures. In terms of our peripheral nervous system, of course, we know that with some of the earliest signs and symptoms, and one of the things that we kind of tell patients to screen for, have you lost your sense of taste or smell? And of course, I always love the fancy words for taste and smell impairment. There's also been patients reporting vision impairment and also neurologic or nerve pain, shall we say. Okay. But the third sort of category that was in this particular article was our skeletal muscular injury. Now, I know that doesn't feel like it's neurological, but they did publish it as part of this particular article. And again, they were seeing, that these patients are having elevated creatine kinase levels. And again, what they think this is due to is those cytokine release is actually directly damaging our skeletal muscles. And of course, we know that we do have a code for that elevated creatine kinase, such as rhabdomyolysis. And of course, it could be traumatic, if I was laying on the floor for hours, but in most of these, again, it's a non-traumatic, it's an illness that's causing the cytokines to be released and again, directly damaging the skeletal muscles. Some other conditions, and again, I'm not repeating everything from my previous webinar. I just wanted to highlight some of the newer things, the more interesting things, or expand. We know that a lot of these patients with COVID have had coagulation abnormalities, anywhere from thrombocytopenia to coagulopathy, or even, again, a DIC, a disseminated intravascular coagulopathy. And again, what you'll see with DIC is understanding it is not just my clotting factors are off. It is a massive syndrome. I like to use that word because it really affects the whole body and is caring for it clinically. These patients were simultaneously having blood clots, but also bleeding out of every pore, out of every IV site, out of their ET tubes, from their eyes, from their wounds. It was actually, from their stomach, their urine. It was a particularly awful looking scenario, and again, is often very fatal. But I have also seen in the literature something described as pulmonary intravascular coagulopathy. There is not an ICD-10 code for this, so how would I code this? Understand that if I look up the word coagulation, intravascular, it will direct us to DIC in our alphabetical index. But this is only affecting our pulmonary bed, so that would not be appropriate to sign the code for DIC here. What they're thinking is happening here is with, not only do I get blood clots in my brain, or in my legs or my lungs, we're actually getting them in our microvascular capillary beds of our lungs. So the tiny areas that are supposed to be doing the actual direct oxygen and carbon dioxide exchange are having blood clots. And so some of our oxygenation problems are not just from the ARDS, but due to these clots in the capillary beds. Again, I think it's going to be interesting to see the research in the next couple of years on, whether or not this is found out to be or not. The other thing, of course, that we know is so many of these patients are having massive and ginormous PEs or DVTs. One of the charts I was reading a couple of weeks ago, it was his entire popliteal vein all the way up to the common femoral. And this was not an inactive person that was laying around. This was a man that was out and about volunteering in his community and had a clot, for a large portion of a vein. Again, clinically speaking, they are acute, of course, but when we start thinking, and as Audrey hinted, what about our subsequent encounters? Some of our patients are being readmitted after that first episode, and we want to make sure that we're capturing, are these clots still present? These large clots dissolve overnight. They're going to be around for several months most likely, and again, we're going to need our providers to tell us, is it still present? And if it is still present, is it now in a more of a chronic phase, or is it an acute phase? Okay. So in terms of gastrointestinal conditions, one of the things that we did know is that our patients are coming in, especially our pediatric ones. We're coming with a lot of abdominal pain and diarrhea, and of course, it is the most common GI system. and you can see that the duration of the diarrhea is fairly long, which is, again, disturbing. But in addition to that, again, several of the charts I was reading, as these patients were having GI bleeds. And actually, I saw a client question on a previous WebEx where they were saying the patient came in with a GI bleed and was incidentally found to be COVID positive. I don't know that was so incidental. In other words, perchance that GI bleed was probably attributable to COVID. Now, again, remember, I'm going to need the provider to provide that relationship. But we do want to make sure that we are getting the appropriate cause and effect from some things that can occur outside of our COVID disease. And, of course, some of our adults and children can only have digestive systems without the respiratory component. And then also just kind of an advertisement, we, as in the medical community, and then we at 3M, don't really fully understand what's happening in the pediatric population. So as more information becomes available, please do watch. We'll probably have some subsequent webinars talking about the pediatric ones, such as this new multi-system inflammatory response syndrome and the Kawasaki. So, stay tuned. Okay. Also, again, I found a very interesting article from the National Union of Dermatologists and Venereologists from France. We've heard incidentally in the United States people saying, well, she's got red eyelids. What is that with the red eyelids? Apparently, again, it's some sort of, again, dermatologic reaction of the COVID directly attacking the skin. Some patients have pseudophosphite of their extremities. Now, that could be showering, microscopic clots showering down to our toes as well. They call them COVID toes. And, of course, we can have some transient hives. And, again, that redness can be very, very painful. Okay. So one of the things that Audrey and I spend a lot of time talking about is what are these cytokines and what does this have to do with COVID and, the whole bit. And, again, I think it's something that has been studied for a long time, but not necessarily in the context of COVID, and we're really understanding it. But what is the difference between our hemophagocytic lymphohistiocytosis, so I'm only going to say that one time, or HLH, what's the difference between that and sepsis, and how are cytokines involved? So what happens, I clicked 2 slides ahead. During an infection or a presumed attack on the body, our immune system increases the release of our molecules, a subset of their immune system molecules called our cytokines. And they're basically like Paul Revere and his horse saying, go fight the good fight. For some reason, in some patients, those cytokines not only are going around and telling their body to fight, they directly damage our organs, and they directly attack not just the virus, they attack healthy organs. And they don't stop after the virus is gone. Typically, what you'll hear even in the literature, the patient was fine at home for a week, and all of a sudden, they crashed and burned into the hospital. Or again, with these children, where it's really a delayed response to this viral infection because my immune system forgot to turn the switch back off. And again, it's causing that collateral damage to our tissues. The particular cytokines involved, and again, this has been studied long before COVID. It's been studied in many autoimmune diseases and sepsis, are a release of a type of cytokine called our interleukins, or IL, and you can see there are different types of interleukins. But in addition to that, we're also having the cytokines are having my body also release tumor necrosis factor alpha. And again, typically our patient is not necessarily dying of the COVID, shall we say, but they're dying because of this massive inflammatory response. Again, typically it's following a flu, Ebola, and sepsis. Okay? Now, in 1 second, I'm going to hand it back to my friend Audrey. When we had cytokine release storm, another cause of that was when patients were getting certain types of chemotherapy. And how do we code that? The cytokine release storm or syndrome. And there was an original comment that said, yes, you can code it and code it to tumor lysis syndrome. And then they corrected themselves in first quarter of this year. And so in our current code book, you cannot find a way to code cytokine release syndrome or cytokine storm. And of course, when you can't code that, you're supposed to code your associated manifestations, such as the neutropenia and all those other things. Again, I'm going to pass it back real quickly to Audrey to give you some late-breaking advice and information on cytokine release syndrome. And I think she's on mute.
That's right. This just in, a breaking news story.
Miss Audrey.
That the Coordination and Maintenance Committee meeting did release, we must be under a delay, Ms. Cheryl. The cytokine release syndrome do have new proposed codes that should be coming effective October 1st, 2020, so just in a couple of short months. They have proposed these new codes. They have released them. You can find this information on the Centers for Medicare and Medicaid Services, CMS.gov. website that this should be approved and released on October 1st, because they have been approved by all the coding powers that be, the National Center for Health Statistics. Now, you'll see that it's broken out under category D89, subcategory 830, with appropriate sixth character to show what grade it is in. So these should be released effective October 1st. Now, what may be subject to change is what DRG it goes into. You'll see down here that right now it's proposed to go to MBC 16, NMS DRGs 814, 815, and 816. That may change, and that's open to public comment. Also, it's now classified, or it's currently classified as a non-CC. Once again, this is open to public comments as well, and that's the sort of information that may change effective October 1st. This was already in discussion by the Coordination and Maintenance Committee. It was discussed at the September 2019 meeting, so they have had time to create this information, to create the codes, and get it ready for release effective October 1st. We'll see what else they do look at regarding new codes that may become effective October 1st regarding other such areas. And so with that, Cheryl, I'll turn it back over to you.
Thank you, Ms. Audrey. So real quickly, and my slide didn't quite get in order, but how do I treat the storm, the cytokine storm? There are, of course, a lot of experiments out there. The most common one that I have seen are the use of what we'll call those interleukin-6 inhibiting drugs. Those are ones that have been currently on the market for a long time for autoimmune diseases. And you can see a couple of those brand names. I'm not going to pronounce those for you. And again, they might try and limit. In other words, I'm trying to dial back that immune system. But the problem is how far back do I dial it back? We want our immune system to continue to fight, and it's trying to balance it out. Other, of course, experimental treatments of steroids, again, depending on the study you read, steroids are good or bad. There is also a study at Washington University in St. Louis, where I'm from, with the use of fluvoxamine, Luvox, because that particular medication, although it's a treatment for OCD, it does bind to a receptor on immune cells so that the cytokinins can't be produced. So it'll be interesting. Certainly, we've seen a lot out about our Plaquenil. We've now seen a second study in which they didn't seem to be effective. Their hopes were meant to inhibit the virus from replicating. And then the most recent one that has been approved, got emergency use for use in the United States by the FDA, was remdesivir. And again, it's meant to block our viral replication. So when you think of a cytokine storm, there's basically one of two things you want to do. Either block the cytokines from going crazy, or actually stop the virus from replicating. But of course, we don't necessarily have a cure, and of course, not a vaccine yet. So what I also wanted to show you is, in terms of that, as Audrey indicated, we have those grades. And actually, one of my clients, the providers have been using this for a long time. And you'll notice it says it's the National Cancer Institute's criteria for adverse effects. So in other words, when a patient is getting chemotherapy treatment and they have a bad reaction, they're trying to grade it and they have to report those adverse effects, so they want it to be universal. So you see grade 1 can be some simple symptoms that we would see, again, like, for example, in our COVID patients. Grade 2, they tend to start needing oxygenation or support, or hypotension needing some support. Grade 3, we're definitely going to have we're starting to get more systemic involvement. Grade 4, ventilator support now. Instead of just oxygen support, we're now up to ventilator support. Or again, they're having grade 4 organ toxicity, and of course, grade 5 is self-explanatory. So in other words, we're going to be looking at our documentation for our providers to use those grades. And if not, those would be some query opportunities. But do remember that, as Audrey indicated, there was an unspecified one. So we've got those cytokines going crazy, right? So we basically say, what are the cytokines doing in the body? Well, if they're either represented as a septic picture, and again, we at 3M are not going to define for you what sepsis is. We know that you need to follow your facility's guidance, okay? If we're going to use sepsis 2, sepsis 3 criteria, you'll notice, though, there's a fair comparison. They're not that different in terms of the criteria they're using. In other words, they're using the same sorts of category. But again, we're not going to define that for you. Okay. That other option that I discussed earlier, are hemophagocytic lymphohistiocytosis. It is also, again, that immune system going kind of berserk. One of the more common causes is a viral infection. There is actually a primary genetic type, okay, but there's also the secondary, or the FHLH. And you'll see that we have an elevated cytokinase, or that hypercytokinemia with multi-organ failure. But if you'll notice the symptoms here, I have fever. Okay, well, I had that in sepsis. We have cytopenia. So not all septic patients have a low white count, and I've seen a lot of these COVID patients coming in with normal or low white counts. They have an enlarged liver and spleen, of course, the neurologic symptoms. But again, what I think has been very interesting when I have looked at a lot of these records is they are running ferritin levels. Why? Because we know it's one of their sort of waiting or determining if they're COVID as they're waiting the results. If that ferritin is elevated, it's probably, again, a COVID patient, meaning they're having an HLH criteria. Again, they diagnose it either by finding that primary type in your the genetic mutation or, again, by the patient having that criteria. But what I will say here, and I want to make sure that it's clear, is whether or not your providers are going to use the AHA penalty or sepsis, that is an individual facility decision. I'd really encourage you to work with your infectious disease physicians. Again, in several of what I'll call COVID hotspot hospitals, I've had the unfortunate ability to see a lot of these records. They are using this terminology. It's something we might not have ever seen before because it was so rare, but we're seeing so much of it. I don't think it's a leap to start discussing, HLH. But again, we're going to have you defer to your infectious disease professionals. So we only do have a couple minutes left, but we want to remind you of resources. This is, Audrey and I obviously presenting. First and foremost, your official source of coding guidance is cdc.gov, the NCHS website. Also, the frequently asked questions on the AHA Coding Clinic Advisor website or the HEMA websites. Again, those are your primary sources of information. Okay, that's where we go to stay current as well. But in addition to those, we do here at 3M have a COVID-19 resource page, and you can see that address is go.3m.com. And by the way, the COVID is case sensitive, as we found out yesterday, all caps. On that page, you will find links to our previous webinars. You'll find that you're able to download the query templates, and you'll see any information about upcoming webinars. In addition to our resource page, our insideangle.com, and again, you see the link at the bottom. And in that middle of that screenshot, you'll see it's by COVID-19. You'll see all sort of blogs posted on COVID-19. So a couple different resource pages for you. Quick screenshot to show you that we do have the 3 COVID templates. On that first one, we're really asking the provider to document all the manifestations of COVID, not just saying they have COVID and pneumonia. This is a much more complicated patient than that in a lot of cases. That second one is trying to get a more confirmatory type of COVID on the case, as Audrey was discussing earlier. And then that third one is if we have a concern about clinical validation, that we're really trying to track. We don't want to over-report this, and I will say briefly, there is a lot of buzz out there in the community that we are over-reporting COVID and that these numbers are being faked. So we have to be the stewards of honest documentation and coding. So this query is definitely included for that reason. And Ryan, I'm going to pass it over to you, Ryan and Jared, I should say.
Great. Yes. So it looks like we have several reports of audio issues, so we apologize for that. We were operating at maximum capacity. So if you did have, looks like there's a little bit of a delay as well, but if you did have some audio issues, we will be sending out the recording and the slides, so you can review that at a later time. We'll move into the Q&A portion. We are short on time, so go ahead and submit your questions. If we don't get to them, we'll be following up via email. You can use the questions feature in your web meeting controls, which is located in the lower right corner of your screen. And then additionally, if you'd like more information about topics from this webinar, I'm going to launch a poll here, and you can select your top interest. That should be coming up on your screen now. And while that poll is live, I'm just going to go over a few reminders. There is a PDF that contains all of the presentation slides that's available for you to download, and it's located in the handout section of your web meeting controls. And again, we did record today's presentation, so a webinar archive will be available. Look out for an email within the next week that includes a link to this archive. And then lastly, we will be providing a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar. Okay, I'm going to go ahead and close out that poll. So we are at the top of the hour. I think what we'll do is we'll just follow up with, we had a lot of questions come in, so we'll be following up via email. And we appreciate everybody joining us today. Cheryl and Audrey, thank you for this excellent presentation. And this concludes today's 3M Health Information Systems webinar.